Good evening, everyone. Welcome to this very special edition of COVID updates from AIG Hospitals. As you know, AIG Hospitals has been conducting this every Tuesday, and we have had world authorities from different parts, including China, Japan, South Korea, Germany, UK, Australia, France, Spain, who have shared their experience. The idea behind these COVID updates has been to help our colleagues and ourselves in sharing the experience from different parts of the world. One, to make sure that we don't repeat the mistakes which have happened in other places, and learn from each other so that we keep ourselves safe and make sure that we give the best treatment to our patients. In that context, this is the 12th edition and this is the first edition as far as the cardiology COVID update is concerned, and we are really happy to have with us pioneer in cardiology from Barcelona, and also a chairperson who is well known both nationally and internationally. So to start off, I would just, it's my pleasure and honor actually to introduce Dr. Ajit Mullasari. People who are there in the country and many parts of the world who are in the field of cardiology, I am sure they don't require, Dr. Ajit doesn't require any introduction for them. But there are a lot of other people who join us, and they would surely want to know about him. He's a great teacher, a great mentor. He's been a pioneer in the field of interventional cardiology. He has brought about a revolution as far as ST elevation MI management in the country is concerned. He has published a number of papers on pharmaco-invasive therapy, and the way we look at ST elevation MI in our country has totally changed after he has actually got involved in the management of STEMI patients. In addition, he has a different perspective also. He is involved in a lot of social service. He does many things as a founder trustee of the Sankalp Foundation, where he takes care of children who suffer from autism. He conducts conferences also. So that's a different aspect of Dr. Ajit Mullasari's character. In addition to all the patients that he treats in Madras Medical Mission, which is a trust hospital, and he is also a avid teacher, takes part in conferences. He has one of the maximum publications in interventional cardiology, and for all practical purposes, he is considered to be a comprehensive cardiologist. You ask any question to him, whether it's about heart failure, about pulmonary artery hypertension, about interventional cardiology, about imaging, I'm sure whenever any cardiologist in this country has a doubt, you just pick up a phone and then give him a call. He always has answers to that. So thank you, sir, for joining us. And indeed, it is a privilege to have you with us. With this few words of introduction, I would hand over to my colleague, Dr. Anuj, who is an interventional cardiologist with us. And I would request him to introduce the speaker for today.
Hello, good evening. It is my pleasure to actually introduce Dr. Salvatore, who is an interventional cardiologist at the Hospital of CLÍNIC de Barcelona in Spain. He is also affiliated as an assistant professor in the Department of Cardiology in the University of Barcelona. He is a social media editor for Europe PCR and EAPCI, and also an editor-in-chief for PCR Online. He has years of experience in coronary and structural heart disease, and does complex interventions like left main and bifurcation, and also in structural heart disease like TAVI and mitral clip and appendage closures. He has special interest in clinical research and medical education, and also has contributed a large amount to actually invent new devices. He is an author for 300 manuscripts and around 300 manuscripts and peer-reviewed articles, and has special interest in preventive cardiology, drug-eluting stents and bioabsorbable stents, and coronary imaging along with TAVI. Welcome, Dr. Salvatore, and I think it's a great pleasure to have you, and we speak about the COVID updates.
Yeah, thank you, Dr. Anuj. I think we'll hand over to Dr. Ajit now, who will be the chairperson for today's talk to take the proceedings further.
Thank you for the kind invitation, Rajeev and Anuj. And thank you, Dr. Salvatore, for coming. We are now in the phase in India of seeing the problem spike. And as cardiologists, we are facing the challenges that maybe Salvatore and his colleagues faced in Europe a few months ago. So it'd be good to listen from Salvatore. So I hand over to Salvatore for his lecture. Please, Salvatore, please go ahead.
Thank you. I would like, first of all, to thank you for the kind invitation, and thank you also for the introduction. So I'm going to share my screen because I prepared some slides. So let me see. Okay, I guess that you are seeing my screen. That is correct.
Yes.
So
yes.
Okay. So I prepared, some slides about the topic of today, which was how to prepare our cath lab and how to manage STEMI patients in these COVID times that we are living today. So I divided, my talks into these two parts. So in the first part, we will see how to manage STEMI in COVID times. Of course, these are recommendations. This is, a specific recommendation on how to manage STEMI in these COVID times, because we all know how to manage STEMI, so we don't know how we can manage as best as we can during this pandemic. And in the second part, so we will talk about some interesting features that we have developed, for example, the PCR online, on how to prepare our cath lab, so for facing these COVID times. So about how to manage STEMI, I guess that there are two important information that I've been here to share. The first one is this one that we have lived actually in Spain, and that the same slide can be projected for many countries in Europe, which is about the reduction of activity that we have faced during the COVID-19 outbreak. So here we see, the number of PCI in STEMI, diagnostic procedure and the structural procedures. So in the time immediately before, so the pandemic, so which was the last week of February, and then the time when we were so in the pandemic, in the peak of the pandemic, so the second week of March. As you can see here, the first problem that we see when we have to manage STEMI is that there is a huge reduction, so around 40% in PCI in STEMI patients. So we see also a reduction in many other kind of procedure, like the diagnostic procedure. We see almost a stop of the structural procedure. But what I would like to focus right now is the reduction of 40% in PCI in STEMI patients. So how did this happen actually? So I guess that the answer to this problem comes from this recent paper from the French group of Nicole Caram, another interventional cardiologist here in Europe of PCR family. So where actually they have evaluated the number of out-of-hospital cardiac arrest. So during the last years, from 2012 up to this year, and you see that so during the 2020, so during the pandemic, when after the Paris lockdown, so there is a huge increase in the out-of-hospital cardiac arrest. So that means that we are doing, or we did actually less PCI, primary PCI in STEMI patients, not because so there were less STEMI patients, but because there were less patients coming to the hospital. So the patients were really worried about coming to the hospital for warning about infection, possible infection for the COVID-19. So they prefer to stay at home, and here we see that this produce a huge increase in out-of-hospital cardiac arrest. So, and this is to me an important message, because the first thing that we have to do is actually to advertise patients that they don't have to stay at home, but they have to come to the hospital anyway, because the mortality of STEMI is much higher than the mortality of the COVID-19, especially because we can treat them so without any risk of possible infection for the COVID-19. The second thing that we have seen in our experience, so when we manage STEMI during this pandemic, is that so a part of patients didn't come to the hospital, and a part of patients so come to the hospital, but with a long time from symptoms to the first medical contact. So the patient who decide at the end to come to the hospital arrived very late,
And for this reason, we have seen a very high incidence of heart failure, so with a much need of ICU. And the ICU, we know that is collapsed by COVID-19 patients, so that is an additional problem that we face when we have to treat these STEMI patients arriving late to the hospital. And also we have seen a higher incidence than usually in other kinds of years, so of mechanical complication, or like, for example, heart rupture. So we have seen, for example, in 1 week, so 4 heart rupture, which is more or less the number of heart rupture that we see in maybe 1 year. So that is something that is related to the fact that those patients who come to the hospital arrive very, very late. And so which are the practical considerations that actually we can see? So once we have advertised the patient to come early to the hospital, so we have to test all these STEMI patients as for the COVID-19 as soon as possible. At least for something that we will show you later, but for something that we need to know where we have to locate this patient, because we cannot mix so patient with COVID-19 positive with patient with COVID-19 negative. So we have to test all these STEMI patients as soon as they arrive to the hospital. And as this test so is not immediately available, at least in our hospital, we need 2 hours for having this test. So we should consider all the STEMI patients that we receive potentially COVID-19 positive. This is important, not for the patient, but especially for the professionals, because so all the interventional cardiologists, the nurses, all the team should be very protected to avoid any infection from the patient to them. Another point that is also to be considered in this patient is to provide them as a complete revascularization if they are, for example, multi-vessel. Of course, if it indicated, if it is appropriate, and if can be done so in a safe mode, so without any risk for the patient. And one thing that I have read actually in the consensus of the EAPCI about how to treat STEMI in COVID-19 time is about the use of left ventricular angiogram instead of echo to evaluate the left ventricular function. So the fact that this fact is guided mainly by the fact that making the echo so the patient can stay in the hospital longer instead of having a left ventricular angiogram at the same time of PCI, so that we can shorten the stay in the hospital of the patient. We can make give him at home as soon as we can. So what is important? So why is important to test the patient for the COVID-19? So we test the patient when it arrives. We treat the patient as a positive, but then so we need to know if the patient is positive or negative, because we need to locate the patient in ICU, so specific for positive patient or not. So this is important as well. We don't have to mix COVID-19 positive or negative patients, because of the risk of the infection that we can have each other. And this is important for STEMI, but also for other kind of patients. Of course, in other kind of patients, we can have some time, to test the patient and to know the result of this test. But for STEMI patient, so we need to test, and we need then to wait. So we need, to locate the patient in some ward, which is a sort of no positive or no negative, and then so to go for the definite ICU COVID positive or negative. And so here we see again that so for non-STEMI, so we need to do more or less the same. So we need to test the patient according to the risk of the patient. So if the patient is a low risk, of course we have all the time that we need to test the patient for COVID-19, and then so we can either decide to perform a non-invasive testing instead of a coronary angiogram, or we can go for invasive testing. But on the other side, for very high-risk patients, although they have no STEMI, but they need, for example, for refractory angina, hemodynamic instability, or other kind of complication that you can read here. So we need to go for immediate invasive strategy as for STEMI. And in this case, in this kind of patient, we cannot wait 2 days or 1 day for the test. So we have to go directly for the invasive strategy. Then another important point that maybe we can discuss later is about the reperfusion of these patients. So there has been, long and huge discussion about how to treat this patient, either by primary PCI or by fibrinolysis, etc., etc. And so we heard that, for example, in China, some hospitals decide to fibrinolyze this patient instead of going from primary PCI. So these are actually the recommendations that are coming in this document published in Neurointervention, the European Heart Journal, from EAPCI, which is the EAPCI consensus on how to treat STEMI during COVID-19 pandemic. And you see here that fibrinolysis is indicated in these patients in the same indication as in normal STEMI, so without the COVID-19 pandemic. That means that everything depends from the time that we can transfer the patient from a no primary PCI hospital or a primary PCI hospital to performing the primary PCI. If this time is not 60 minutes more delay, so that means that we can perform the primary PCI timely. So we have to go for primary PCI. Otherwise, if, for example, the patient for this COVID-19, so is not possible, to transfer to a primary PCI hospital in a time proper time. So of course we have to do fibrinolysis. What is important, to stress here is that although we treat the patient with fibrinolysis, anyway, so we have to perform thereafter, at least during the 24 hours following the fibrinolysis, the angiography of this patient. So in any case, so although we perform fibrinolysis as the first step, the patient should undergo coronary angiography during the following 24 hours. So it's a sort of strategy where we can save some time, but at the very end, so the last step, so will be anyway, so the coronary angiography. So we have to think about how to transfer the patient for performing primary PCI in a time way. Then, so these are more or less, the problems that we have seen in STEMI during these coming times. So we move to some important tips and tricks that I want to share with you on how to prepare your cath lab and to prepare also yourself to treat these patients. So the first thing is to protect yourself and to recognize what have to go to the patient, the circulating staff in your cath lab or the operating staff. The most important thing, I guess, in this table, so is the fact that the patient should wear in any time the surgical mask. So that is very important. I remember at the beginning of this pandemic, so the patients were coming still in the cath lab without any surgical mask, and a lot of interventional cardiologists so were infected by this fact. But if the patient wear this surgical mask, the risk is reducing, and actually is reducing much more than you think. And then, so the operating staff, the circulating staff nurse should wear all these fluid impermeable glove, FFP2 mask, so everything that is here in this table. You see that there are not much difference between what is wearing the circulating staff nurse or the operating staff. So the only difference is about the gloves, which have to be double in case of operating staff, because every time that you need to go in and to go out, you need at least to keep a sterile glove to disinfect yourself. And so there are also important tips and tricks to take into account before, during, and after the case. So before, so not only you have to be sure that everyone so knows what you have to wear, but also that everyone should be aware and well trained about the correct and appropriate use of this PPE. And this is something that has to come from the hospital, from you, so everyone should be trained. This is something that cannot be done so when you're receiving a STEMI, so you have should be done very in advance. So everyone should practice, should be very aware on how to do it. And an important thing that you can think about is, for example, to make a video of yourself. One of your colleagues can make a video of yourself donning and doffing, just to see and to understand if you are doing the things correctly or not. But always, so without the patient in the lab. So in a time free that you can have, so you can actually practice. And in this way, so when you receive the patient, you know very well what to do. And of course, I mean, only the person involved directly in the procedure should remain in the room. The other ones should go outside the room. So the process on the how to dress and how to undress is very complex, at least. So it looks very complex when you have to do the first time. And you can see here in this slide, so it looks also very complex. But you have to know very well the process. And if you look, for example, to PCR Online, so we have done a specific cube on COVID-19. And here there are some videos which are being provided by by some colleagues from London, from the Imperial College. And you can see here in the video how to doffing and so how to dress yourself, to undress yourself. And it's always, I mean, easier to see in video what we have to do instead of reading a paper. So I advise you, I mean, to have a look and at least to know very well all these procedure. Then, so during the procedure, so of course the doors should be closed. So you have to avoid the entry and exit from the room. So all the kind of material should be in the room: catheters, stents, balloons, everything. If you think, for example, to use IVUS on OCT, this kind of device should be already inside the room. So you should avoid to open the door to go in with the IVUS or with everything. You have to minimize the contact with the surface, so especially the circulating stuff which is inside the room. So every time that you touch, for example, surface, tables, etc., should disinfect it, so they should wash their hands. And last but not least, so you should keep the procedure as simple as possible. So try, of course, to maintain a good clinical care for the best outcomes. So try, I mean, to not complicate yourself with the 2 stents strategy, 1 stent strategy, but try to fix the problem. So in the best way you can, the simplest thing you can do it. And then, so after the procedure which has been done in your cath lab, so of course, so you will be sweated because after, I mean, half an hour procedure with all these stuff which is wearing you, protecting you, so you are very tired. You want to open the door of the cath lab, but please, so keep the door closed, okay? You have to perform the doffing still inside the cath lab, so you don't have, I mean, to go out on the cath lab immediately, but you have to perform the doffing, so inside the lab, and then so you have to go out still with the mask, which should be removed outside the cath lab, because inside the cath lab there can be the possibility that there are still some aerosol and you can contaminate yourself. So the mask should be removed after you have go out from the cath lab. When you remove, for example, your material, so this material is contaminated, like for example the gloves, and these gloves should not be squeezed inside the waste material, because otherwise, so you are creating some aerosol. And the most important thing is that so you finish the procedure, so the patient go out, you go out, but the door should be closed, and then you have to wait at least 1 hour. So to clean the room, so that is also important, to allow that aerosol to deposit, and then so it can be clean. Otherwise, so there will be some aerosol, and during this cleaning process, some aerosol can go out and can contaminate so your personnel. So I hope that so this very brief, I mean, tip and tricks on STEMI, so will help you. I guess that the take-home message to me are this one. So dedicate, I mean, in case you have 2 cath lab, 1 cath lab for this suspected or confirmed COVID-19 STEMI patients. So that is possible. You have to establish clear pathways for COVID-19 patients, so very separated for COVID-19 negative patients. So that is very important. Surgical mask, so should be worn all the time, but all the personnel and also by the patients. And you have to be, so all the personnel should be very trained in the correct use of the PPE, so how to dress and how to undress. And the last thing that I found, I mean, very useful, at least in our experience, is to split your personnel into 2 teams, which means that one team so works in days where the other team is not working. In this way, so you keep one team of your personnel so clean if, for example, there is a contamination in that day, and then you can use the other team so to work in your CATH lab. So thank you very much.
Thank you, Dr. Salvatore. That was almost like tips and tricks of handling patients with STEMI in COVID times. I am sure all those who are listening to this talk will indeed be much more comfortable in handling this type of patients after listening to all those suggestions which you have made. I think there were some questions which were directly sent. One of them was the issue about there has been a lot of talk going on in news channels and in social media of the number of acute coronary syndromes showing a significant decline during COVID times. And to some extent, medicine and medical professionals have also been blamed for it. What has been your experience there in Barcelona? Did you find that decrease in the number of cases with acute coronary syndrome, or it's just that they are not reaching the hospital in time?
Yeah, I mean, our experience is what I showed you in one of the first slides. So has been a huge decrease in number of STEMI. So that is was around 40–50%, and that is something which has been confirmed in all the region and also in all the countries, so not in Spain. And when we have seen this, actually, so we thought that there was something isolated there that maybe happened only to us. But then we were happy to see experience of other countries of colleagues from, for example, from Italy, from France, from UK, from Germany. So everyone actually has experienced a reduction in ACS. At the beginning, so we didn't know what was going on. So we were thinking, for example, about the fact that the people were advised to stay at home, that maybe they were not moving, so they were not exposed to pollution, and that there could be also a reduction actually in the STEMI because of this lower exposure to contaminants or to movement, to stress, for example, of work, etc. But then, so I've seen, the paper that I shared with you published on Lancet Public Health, so by these French colleagues. And actually, so I understood that there was maybe, the incidence of ACS was actually the same, but the patients were less coming to the hospital. And that was translated in a higher incidence of outpatient cardiac arrest. That actually, due to this pandemic, it's difficult to understand if it was due to the pandemic, to the COVID-19, or to the ACS, but it's something that we should reflect. Because, so we have seen actually a reduction in ACS, but so I guess that the patient has stayed at home. And it was difficult, and now after 2 months, we see that the patients are coming again. So the incidence, so I guess that it was the same, but the problem was that the patients were not coming to the hospital because of fear to be infected.
Yeah, and I'm sure many of the colleagues are always worried that some of these guidelines which have been put in place are easier said than done. In this regard, what were the challenges which you faced initially when patients with STEMI, with the surge of COVID started coming in? Though we know, okay, this is the donning protocol, doffing protocol, the doors have to be closed and cleaning. But when the patient comes there in cardiogenic shock, people jumping around trying to save the patient, somebody rushing to intubate. What were the challenges which you faced, and what were the learnings from that, and how did you improve on that to make sure that the healthcare workers remain safe while still giving the best to the patient?
Yeah, I mean, the best way is that you receive the patient and you are already with all the protection. So with the double mask, a surgical mask, FFP2, etc., etc. So, and everyone, so within the CATH lab, so should wear completely all these wearing, okay? And then, so according to the condition that you know that the patient is coming to the hospital, because if the patient is already in cardiogenic shock, and is going to be intubated, so you should aware already the anesthesiologist to come inside your CATH lab, to wear with you, to stay inside the room, so with you as well. And so if the anesthesiologist is already coming, so before the patient to your cath lab, and it wears as well, so all these donning procedure, etc. So of course the risk of infection is not zero, but can be, reduced, in a good way. Of course, it's difficult. I have seen, for example, some colleagues saying that so when you have to intubate, you have to stay away from the patient, or you can use a plexiglass screen in order to separate the anesthesiologist from the patient. Everything can be done, but I guess that the most important thing is the plan. So if the patient comes to the hospital, you know already a few details about the status, the clinical status of the patient. You can prepare your team, you can alert the resident anesthesiologist, and you can wear so already all the staff in order to be present when the patient comes, to intubate if needed, and to treat in the best way as possible.
Yeah, Dr. Ajit, your experience, Chennai has seen a huge surge, and I think yours is the center which gets one of the maximum number of STEMIs. Your experience and learnings, and what you would suggest to all of us, the do's and don'ts in the Indian scenario.
So our experience has just been put into a paper form, and it's just getting published. It's a 2-center experience from us and Coimbatore with my colleague. So this is, we had the similar sort of a number looked at. We had a lockdown in the country on 24th of March, which the country closed down completely. So we collected 40 days data from 24th to 1st. It was not absolutely during the spike of the pandemic, but it was in the early part of the pandemic in Chennai. We looked at 40 days prior to that. That is a time when normal, interventions and PCI for STEMI goes on in the country. So 2 things, the numbers, we had 360 patients studied between 2 units. So average, we see about 180 STEMIs a month, each of us. So it's 5 to 6 STEMIs is our number per day in the hospital. So with 360 STEMIs over 40 days, we found, interestingly, like you said, that there was 228 STEMIs in the pre-lockdown time, and that came down by 52% in the lockdown time. I'm talking only about STEMI. I don't have the non-STEMI data, but I'm just talking to you about the STEMI. The second most interesting thing was, which we found very unusual in Chennai, was the young STEMIs. When I'm talking about young, it's less than 45 years of age. We published this in JAMA 2 years ago. 22% of patients in India are less than 45 years of age who have STEMI. This group of patients completely disappeared during the pandemic. And normal times, if you looked at that first pre-lockdown time, was 22% exactly. During the lockdown, it became 7%. So a remarkable fall in young STEMI patients coming in. The third thing we found, that the standard of care, which is basically primary PCI plus pharmacoinvasive in our hospitals in Chennai and Coimbatore, came down, and thrombolytic standalone went up. The delay of total ischemic times was from 220 minutes to 290 minutes. There was a 70 minutes more delay of patients coming in. And interestingly, we found no difference in mortality despite this mortality. But I should say this was very early in the pandemic. We are just collecting the next 40 days too and seeing what happens when it peaks, that the mortality changes. But I think what we have suggested in this publication is, one, that we have a 52% fall, which is like worldwide. We think that young STEMI disappears. And the reason why young STEMI disappears may be because in India, people don't smoke as much as at home, and the access to cigarettes is much lesser when you're at home. We also had, the particulate matter checked in Chennai and Coimbatore dropped from 52 to 26 of 2.5 millimeters. So I think the particulate matter did fall, just like you suggested, but whether that is a cause and effect, I'm not so sure. But I think smoking must be one of the issues, because we couldn't get cigarettes that easy, and people don't smoke as much at home. And finally, I think that what we are now seeing is that there are more and more patients, and they do exactly what you're doing. We have an emergency room which is treating every STEMI and non-STEMI and every heart failure as COVID positive. But they come in, they all get treated as if they are COVID positive. They get a RT-PCR done, which we get in 3 hours time. But if it is a STEMI and it's a young STEMI, or it's a high-risk STEMI like a 90-year-old, they go in for a primary PCI. The low-risk STEMI, we use thrombolysis now and follow it with pharmacoinvasive therapy within 24 hours, because it becomes more safe. We have one cath lab, which is negative pressure, and we try to restrict people into that cath lab. And we close that cath lab for about 2 hours if we can, so that it is cleaned up and nicely. Our ER has also got negative pressure now. The windows, there's an exhaust which pushes off the. We stopped the COVID-19 from ER now. We just call one intensivist who's on call directly by phone, so that there are not too many people. And that person is the only person who will come in quickly to intubate, and he usually will come in quickly with and don a PPE-1 and intubate the patient. Till as much time we mask the patients and bag it. We don't use aerosol producing procedures, no nebulization in the hospital now anymore. It is just simple plain steam inhalation for patients if they need anything. So I think it's more or less the same as you said, Salvatore. But one thing I found in India was that the young migrant, and you'll see it, Anuj, and maybe it would be useful if you see it in Hyderabad, if your young MIs come down during this pandemic.
Yeah, actually, we didn't see, any reduction, or at least we didn't study any reduction in young patients. But for the rest, we have seen the same things that as you have seen, you described. Another thing which was curious, actually, so talking about, for example, non-sterilization MI, so actually they disappeared during the pandemic. So there were maybe 1 or 2 per week. And especially the most interesting feature was that there were not 3 vessels. So it was just one vessel, we fixed the vessel and that's it. So 3 vessel disease, so disappeared as well. That is at least our experience, which was good actually, because the surgeons were involved in other kind of procedure for COVID-19, so they were not operating at all. But it was, something curious. So no 3 vessel disease, no left main and 3 vessel disease, so high syntax score, but just a few no-STEMI with 1 single lesion, and that was our, experience. That I guess is the same experience worldwide.
Actually, our center also, I think it's quite a while we've done a primary on a young person. I don't know, today I was not there, so we had 3 primaries today. Rajeev would know if we had any young primaries.
Yeah, I think that's a very interesting thing which Dr. Ajit has brought up. We had some experience with around close to around 170 primary patients in the IT sector of Hyderabad, and compared to the other places where we were functioning, where the incidence of young MI was close to around 22%, we were surprised that the incidence in this area was close to around 38%. And the primary reason seems to be related to smoking. And as Anuj was mentioning, after this lockdown has started, we have hardly seen any young MI. Most of the patients who have come to us with MI now are slightly in the elderly age, the typical MI cohort which we tend to see. So that's a very interesting finding, and probably it sends a lot of signals to the government as to what their priorities should be to reduce the incidence of heart disease probably, and to individuals what they should do right to make sure that they don't land up on a ventilator or on a cath lab table. So that's a wonderful point, Dr. Ajit, which you have mentioned. The other aspect was some people have asked if we have any data on the imaging and confounding factors because of COVID as far as the cardiac imaging is concerned? Do we have any literature as of now, or is anybody studying? Like typically a patient has a MI, we are doing the viability studies, and then the same patient, when he has COVID, cardiac MRI, how it might be totally different compared to somebody who is non-COVID, and can we interpret the findings similarly in both COVID and non-COVID times? I'm not sure about that. If anyone has any experience or anyone has heard anything regarding that about cardiac imaging as far as COVID times is concerned.
I have seen, if I remember well, just single case which was published in a European Heart about fatal myocarditis in a young lady, so around 30 years old. And that is, I guess, the only thing that I know about this involvement of COVID-19 on heart, so with some imaging. And then I read, a few weeks ago about the tropism that the virus can have on this ACE2 receptor, which is also located on the heart. So I don't know, if you have maybe more experience of MRI in this COVID-19.
I have no experience with MRI, but there's one experience which I have, which I think is another thing which we should all be careful with. I'm not sure Salvatore must have also seen it. That you treat these MIs and, they're not very sick when they come in, and, start treating them, and then they come in either COVID negative or COVID positive. The other thing is to not let your arm down when it's RT-PCR negative. You can have the next RT-PCR coming positive. So it's important to treat, even if you're RT-PCR negative, the whole ICU should behave like an RT-PCR positive patient as much as possible, even though, like what Salvatore said, we have two ICUs, one for positive patients and one negative patients. What they develop sometimes is that's one thing we should be very careful. If they start developing on the next day some patches in the lung, or they start slowly showing a D-dimer going up, I think we should be very, very careful. These patients do badly, and they require sometimes very quickly non-invasive ventilation. They may be just simple inferior wall MIs which you put a stent in very easily, but they start behaving badly like the sick patients. They start getting patches, they desaturate, and it's part of the infection and sepsis. And I think it's very, very important that these patients understand that, that though it's a simple right coronary, you did a 5-minute stent, but they start behaving like a shock patient after some time, and they start doing. I agree, we had 2 ruptures, 1 mitral regurgitation, and 1 ventricular septal rupture, which, as you said, is very unusual in the normal scenario for us in 1 month. I think mechanical that's possibly because of delay, I think, and sick patients.
Yeah, and I think we being cardiologists, people keep asking us, what is your take on healthcare professionals or cardiologists dealing with these type of patients, whether they should take hydroxychloroquine as prophylaxis or would tend to avoid it?
Well, we don't take it. In fact, in the initial part, the ICMR, the nodal agency, had asked us to take it for everybody, but we stopped it about a month and a half ago once we noticed the negative outcomes of and especially after the recovery trial, nobody takes it now. But I think that what the important thing is that we have in our whole hospital, from the time we started, we have 30 healthcare workers infected till now. And despite reasonable, we're doing what we could. And this is very important. And some of the learning we learned is if you have a patient who is sick, like a diarrhea patient with COVID is extremely sick. Be very careful. These patients will infect and they go down very quickly. They are the highest viral loads. The other patients are people who come with a patch or with small, ARDS like, fluffy shadows in the chest. They're very high. So it's very important that a good intensivist intubates, and we use a full cover and a laryngoscope, video laryngoscope to intubate those patients so that we don't get infected. And a junior registrar should not intubate such patients. because they will create problems for themselves and could infect a lot of people around them. So we had 30 people who got infected in the hospital, right from the OPD to the surgical theaters to the cath labs to the, the cleaning boys and so many people. And of them, what was interesting, it was only one of the intensive care people. It was mostly in the outpatient department that people got infected. Many of the people who got infected were simple people who were cleaning, whose level of PPE was not as much as an intensive care person. And I think it's very important that we understand that the infectivity is more in the outpatient department rather than in the intensive care and the cath lab, where we are reasonably well protected and careful, where we are not in the OPD, where you can get into trouble with these patients.
Anuj, anything from your side?
I think unless and until it's necessary, as Dr. Ajit was saying, we should avoid outpatients as much as possible at this point in time, especially in India when we're getting to the surge now.
Well, I think it's difficult not to have an outpatient, but what I would suggest, again, this is a learning which we have learned in the last 1.5 months, is to wear a N95 mask, because it's easily available in India now, and all healthcare professionals should wear N95 masks. And number 2 is to wear the simple shield. That shield is a very protective agent in the OPD, because I think we all wear it 100% in the OPD, to just avoid somebody coughing or somebody, The other thing is to keep our OPD is half the strength now. Normally we used to see about 200 patients in the outpatient department per day. So now it's like half at about 100, so that we restrict entry. Some people, chronic patients, we allow only video consults. It's only patients who absolutely need to see you that they come. But I think end of the day, ultimately patients will come and you need to look after them. And I think you need to be a bit more careful. But despite all what you do careful, you'll still get infections from unknown, sources. It's a very infective organism. That much is for sure.
Yeah, I am sure whoever heard the discussion today would be feeling excited. So many wonderful points which we have learnt, and I am sure taking this forward will keep ourselves safe, will give the best possible treatment to the patients, and come out victorious against COVID. And hopefully next year by this time we won't have these issues, and we'll be discussing about proper interventional cardiology topics rather than the infectious diseases which are totally changing our practices. So it's been actually something which probably many have never seen. We have never seen any time before, and it's a kind of exciting as well as an interesting experience. It's a bit threatening, but surely I think humankind will pass over it, and then we'll live another day to make sure that we do something better for our patients. So with that, I think we'll close the discussion for today, and thank you so much, Dr. Salvatore, and as usual, Dr. Ajit, fountain of knowledge, and then continuously telling us multiple points. Thank you both of you for joining us and sharing your experience, and anytime we have any issues, we'll surely get back to you to get clarifications and take advantage of your vast experience. And thanks, Anuj,
I'd like
for
to just
joining.
conclude one statement today.
Yes.
Today evening we have the first data with dexamethasone, which is showing decreased mortality for the first time as a drug in the recovery trial. It was up on the net, and so I think there's the first drug now in sick patients who are on oxygen or ventilator, decreasing mortality by quite a amount.
Yes.
So I think that's great. At least we have something to look forward to.
Sure, we were just thinking of starting some radiation tomorrow, but by that time dexamethasone has come up. So hopefully we'll try to use that instead of radiation tomorrow. So thank you again everyone for joining, and we'll close the discussion for today. Thank you.
Thank you. Thank you. Bye.